Hi everyone, I am Anjali, audiologist of Bangalore Hearing and Implant Institute. My topic is systematic approaches for in pediatric group. Moving on to the first slide, importance of detecting hearing loss in children, which means early identification and intervention are critical for both speech and language acquisition in children. According to National Institute on Deafness and Other Communication Disorders, approximately 12,000 newborn babies with hearing loss are identified in every year. Early screening and treatment plays a vital role in minimizing the effects of this hearing disability. If the child hearing loss is detected early, the child can undergo rehabilitation before the month of 6 months. The child will achieve better speech and language and educational success. Associated medical condition can be identified and managed early. The child auditory system will develop better. The burden of stress within the family can be reduced. Risk criteria of newborn babies include prolonged neonatal intensive care, that is more than 5 days, family history of congenital or delayed onset childhood sensory neural hearing impairment, congenital infection known as suspected to be associated with sensory neural hearing impairment such as toxoplasmosis, syphilis, rubella, cytomegalovirus and herpes. Craniofacial anomalies including morphologic abnormalities of the pinna and ear canal, birth weight less than 1.5 kg, hyperbilirubinemia, which means increased level of bilirubin in the baby's blood at a level exceeding indication for exchange transfusion. Ototoxic medication including but not limited to the aminoglycosides used for more than 5 days and loop diuretics used in combination of aminoglycosides. Bacterial meningitis, which means infection of the membranes, that means the meninges which protects the brain and the spinal cord. Stigmata to other findings associated with syndromes known to include sensory neural hearing loss, birth complications such as difficulty during birth, asphyxia, which means lack of oxygen, can also contribute to hearing loss. Chronic ear infections such as repeated or untreated ear infections can lead to hearing loss in children. Parental awareness and involvement should be included in the intervention program of hearing loss in children, which means observation of speech and language milestones. Regular hearing screening should be conducted. Timely intervention should be provided. Encouraged communication strategies. Educational awareness should be provided. Signs of hearing loss in children include delayed speech and language development, difficulty in following instruction, frequent requests for repetitions, lack of response to sounds, speech mispronunciation, such as they will omit or substitute some words or sounds, volume adjustments like turning up the volume of electronic devices, social isolation, which means they will be avoiding to play with the peer groups. They will be isolated, inattentiveness or distraction, tilting or turning head, speech regression, limited vocabulary, lack of startled response, complaints of ear pain and ear discomfort, lingering of baby talk, lip reading, difficulty in localizing sounds. Localizing means from which side the sound is hearing, they can't localize. Avoidance of certain activities, regression in auditory skills will be noted. Types of hearing loss in children include conductive hearing loss, sensory neural hearing loss, mixed hearing loss, auditory neuropathy spectrum disorders, which means ANSD, central auditory processing disorder, CAPD, functional hearing loss, unilateral hearing loss, genetic hearing loss, and syndromic hearing loss. Conductive hearing loss means there is a problem in the external ear and the middle ear. The sensory neural hearing loss means a problem in the inner ear. Inner ear means the cochlea or the neural pathway to the auditory cortex. Mixed hearing loss is a combination of both conductive and sensory neural hearing loss. The ANST means there is a damage somewhere in the auditory or hearing nerve. This is the pathway between the inner ear cochlea, which takes sounds and turn them into messages. Which means this is the pathway between the inner ear and the brain. Next, the children who are born early or having a family member with ANST tend to have ANST. Central Auditory Processing Disorder CAPD. The kids with this condition can't understand what they hear like other kids do. This is mainly because the ears and the brain don't coordinate fully. Something interferes with the pathway from brain to the ear. And others are, as we already mentioned, other hearing losses are functional hearing loss, unilateral, and genetic and syndromic hearing loss. The implications of interventions include speech and language development, academic development, social and emotional being, cognitive development, adaptive skills, parental and family dynamics, speech and articulation skills, auditory processing skills. Overall, the child quality of life will be improved. Next, moving on to the importance of interdisciplinary collaboration. Multiple professionals are involved in providing services to children with hearing loss and their families. The goal of team management is to have all involved professionals provide services in a coordinated way to a child with hearing loss and his family. Observation made by one clinician are helpful to the other clinician in understanding the child's overall performance and behaviors that can help clinicians to improve their individual recommendation. The composition of team will be different for every child and it will depend on the child's individual needs. The role and responsibilities of an audiologist is audiologists play a central role in the identification, screening, assessment, diagnosis, management and treatment and overall rehabilitation of children who are deaf and hard of hearing. They maintain knowledge of the anatomy, physiology, pathophysiology of the auditory and balance systems. Remain current on research and best practices related to childhood hearing loss and help to advance the knowledge base regarding its causes, identification and treatment. Remain current on technology, example devices, applications and accommodation designed to facilitate access to speech, language, social interactions and or classroom instruction for students who are deaf and hard of hearing. They also serve as an integral member to an interprofessional and collaborative team working with children who are deaf and hard of hearing and their families. Screen infants and child for hearing loss. They will diagnose hearing loss through comprehensive audiologic assessment, which includes the behavioral and electrophysiologic methods of assessing hearing and auditory function. They will report screening, diagnostic test results to state early intervention programs, public health agencies, or school representatives. Refer to appropriate professionals to rule out other conditions, determine etiology, and facilitate access to comprehensive services. And the audiologist will counsel children who are deaf and hard of hearing and their families on topics such as potential impacts of untreated hearing loss on language learning, psychosocial development, self-advocacy strategies, and rights to educational and other community services. They will fit and that they will means that the audiologist will fit and maintain any hearing technology used by the child and ensure optimal performance. They will collaborate with an interprofessional team to develop and implement an appropriate and comprehensive child and family centered audiologic rehabilitative management plan. Medical professionals. The intercollaborative team also includes the medical professionals. Every child with hearing loss will receive medical services from at least 2 physicians, which means a pediatrician and an otolaryngologist, ENT specialist. The pediatrician will manage routine medical issues and the otolaryngologist will be responsible for ear-related issues. And the next role is speech language pathologist, which means SLP. A SLP is an integral member of the interdisciplinary diagnostic system that serves children with hearing loss. A SLP with specific training in the provision of auditory therapy for children with hearing loss or an auditory verbal therapist needs to be involved in the evaluation and management of all children with hearing loss. As soon as the hearing loss is identified, at least annually, thereafter the child's speech language should be assessed. It should be a mandatory thing to assess or screen after the newborn baby is born. This evaluation will include assessing and monitoring the child's performance with his technology and participating in determining the need to change technology, example to new or more powerful hearing aids or to shift from hearing aids to cochlear implants. After speech, language and auditory assessments are conducted, recommendations are made for appropriate therapies and for providing training and coaching to parents to enable them to carry therapy over at home. When a child reaches school age, services may move from the clinic to school. The communication profile of children with any degree of hearing loss are characterized by a wide variability in functional listening skills and linguistic competency. Therefore, for any child with hearing loss, the communication evaluation should encompass a functional listening assessment. This component is needed to obtain critical information about speech perception abilities, which means, for example, the nature and extent of hearing aid or implant on the user's reliance on auditory input for continued language learning, literacy development, and enhanced communicative interactions. This functional listening assessment requirement distinguishes the speech language assessment of a child with hearing loss from the communication assessment of his normal hearing peers, because formulating and implementing oral rehabilitation or habilitation training also fall within the professional domain of the SLP. The others who are included in this collaborative team is the social worker, ophthalmologist, psychologist, occupational and physical therapist, special education teachers, genetic counselors, and at last assistive technology specialists. The intervention of counseling include the impact of hearing loss on child development, language and communication modalities, coping and compensatory strategies, identification and response to barriers to effective implementation of amplification or other supports. As a member of an interprofessional care team, the SLP also plays key role in counseling the child or family regarding speech and language and communication needs and the effects of hearing loss on child development. Referrals for formal counseling by a mental health provider, example, A school counselor, psychologist may also be indicated. Realistic expectations for treatment should be provided. It is a mandatory point should be provided to the child family. The Joint Committee on Infant Hearing endorses a 136 global benchmark for hearing loss identification and intervention in infants. The goals include the following, such as all infants undergo a hearing screening prior to discharge from the hospital and no later than 1 month of age. All infants who do not pass their newborn hearing screening or re-screening are referred immediately for a comprehensive audiologic and otologic evaluation to be completed by 3 months of age, which means the comprehensive audiologic test means the newborn babies will be screened by a test which is called autoacoustic emissions. If in that test the baby is failed, the child should be undergone ABR, which means auditory brainstem response. All infants identified as deaf and hard of hearing receive a referral for early intervention services immediately after diagnosis and no later than 6 months of age, along with access to audiologic services including appropriate hearing aid, cochlear implant, and hearing assistive technologies as determined by the child's needs and the family preferences. The comprehensive audiologic assessment include the purpose of the comprehensive and child-centered audiologic assessment is to assess the integrity of the auditory system in each ear, measure hearing sensitivity across frequencies, determine the type of hearing loss that is conductive, sensory neural or mixed, establish a baseline for future monitoring, provide ear-specific information needed to guide the selection or fitting of hearing technologies, assess any impact or possible impact of hearing loss on daily function and quality of life, initiate child and family education. Assessment of hearing loss in children start with the case history. Case history is which includes the demographic details, birth history, prenatal and perinatal factors, family history, developmental milestones such as speech and motor milestone, ear infections, speech and language delays, medical history, results of genetic testing, current communication status and needs. Developmental and communication screening, which means a complete audiologic assessment typically includes a developmental screening to assess the child progress on reaching developmental milestones. Audiologists and speech language pathologists are involved in developmental screening and functional auditory assessment. Children who are deaf and hard of hearing typically receive a complete developmental assessment and are evaluated across various domains. Example: expression, reception, cognition, communication, speech skills and social skills, adaptive skills, etc. Areas that are monitored include developmental milestone, pre-linguistic communication, receptive and expressive language status, auditory skill development, functional auditory performance, social and emotional development. Next, otoscopy. Otoscopy means examine the ear canal and the tympanic membrane for any visible abnormalities or signs in children. Tympanometry is a simple test. It measures the movement of the eardrum in response to changes in ear pressure. It helps to assess any middle ear function and can identify conditions like fluid in the ear or there is any wax or ear infection. Acoustic reflex testing includes, it provides the information about the integrity of the acoustic reflex pathway, which includes the middle ear, inner ear, vestibular cochlear nerve, cranial nerve 7 and lower brainstem. ART, the sound pressure levels at which the acoustic reflex is triggered are measured ipsilaterally and contralaterally utilizing 500 Hz, 1 kHz and 2 kHz stimuli. In infants under 9 months of age, use of a single higher probe tone frequency, example 1000 Hz, provides a more reliable measurement. ART are considered normal if they occur between 85 dB SPL and 100 dB SPL. Elevated or absent ARTs are suggestive of disruption within one or more of the structures along the acoustic reflex pathway. Depending upon the degree and location of the pathology, transmission of the probe tone signal or measurement of the ART may be affected. It can be used to determine the site of lesion or location of auditory pathology. Acoustic reflex testing is a valuable component in the differential diagnosis of children with suspected auditory neuropathy, as ART would be expected to be absent in all conditions. Next, moving on to the autoacoustic emissions, which is a screening test in newborn babies. It is also a very simple and reliable test. It is a valuable component of the pediatric audiologic assessment as an objective measurement of cochlear function. A sensitive probe microphone measures sound generated by functioning outer hair cells in response to tonal stimuli. Since measurement of OAE is dependent upon normal transmission of sound through the middle ear, it is beneficial to complete tympanometry prior to measurement of OAE, especially in children with suspected middle ear effusion or history of the same. In children with auditory neuropathy or other neural or post-neural auditory pathologies, OAEs are expected to be normal despite abnormal hearing disabilities. For this reason, OAEs are performed in conjunction with other tests of threshold estimation and cranial nerve 8 integrity if auditory problems are suspected. Absent OAEs may be a sign of a problem. It could be hearing loss, sacs in the ears, fluid or infection in the middle ear, or malformed inner ear. Moving on to the next test, auditory brainstem response, ABR. An ABR test is used to detect hearing loss and often used if a newborn baby fails in the hearing screening test, as we already mentioned about the OAE. In that test, if the baby fails, we move on to this test, ABR test, which is a comprehensive audiologic assessment. There is tonal ABR, which provides frequency specific threshold estimation. Click ABR provides information about the intactness of the auditory pathways, including measures contributing to the diagnosis of the auditory neuropathy. Automated steady state response, ASSR, it is obtained utilizing amplitude and frequency modulated pure tones with carrier frequencies of 500 Hz, 1000 Hz, 2000 Hz and 4 kHz. The specific method of analysis to define threshold is dependent to the manufacturer's statistical detection algorithm. The clinical utility of ASSR as a test measure for threshold estimation in infants younger than 6 months is being investigated. Next, moving on to the other test, which called Behavioral Observation Audiometry, BOA. The age range is from birth to 6 months. It can be used in conjunction with electrophysiologic assessments. to screen or predict hearing ability in infants up to 6 months of age or in those who cannot complete pure tone testing. During BOA testing, the audiologist will observe the infant behaviors, for example, sucking, in response to sound. It is best if the infant is texted by hungry and able to have a bottle or nose, or while resting quietly and sucking on a pacifier. Responses are unlikely to be captured down to levels consistent with the infant's true hearing thresholds and are more approximately described as minimum response levels. BOA allows a family member or caregiver to observe an infant's response to sounds, which can help them better understand their infant's hearing diagnosis. This test technique alone is not adequate for diagnosis of hearing loss or fitting of amplification devices. However, it can be used as a functional benefit for hearing technology once fit. BOA may initially be completed in the sound field condition utilizing warble tone band stimuli prior to attempting testing with insert earphones if there is any contradiction. Next text is visual reinforcement audiometry or VRA. In this, the age range is 5 to 36 months. This test method requires that the infant have the developmental ability to respond to conditioned procedures, sit, maintain head control, and turn their head. Correct responses are reinforced with visual stimuli, for example, flashing light, moving toys, or video clips. A test assistant may be present to center the child focus between stimulus presentation utilizing equate distracted, for example, stacking blocks or stacking rings. It is important that the distracted be less interesting than the visual reinforcement. Initial testing is typically performed in the sound field utilizing warble tone at octave intervals between 250 Hz and 4 kHz. Audiologists may begin by obtaining low frequency, for example 250 to 500 Hz, and a high frequency, example 4 kHz responses, and then proceed to other test frequencies if the infant has not fatigued. Minimum response level are typically obtained down to 20 dB HL. If the infant can reliably complete VRA in the sound field, testing may then be completed utilizing insert earphones. If testing results are consistent with a hearing loss, bone conduction testing may be preferred to determine the type of hearing loss, which means the type means which is sensory neural hearing loss or conductive hearing loss, or there is a mixed component can be ruled out in this test. Next, moving on to the conditional play audiometry CPA. In this the age range is 30 months to 5 years. CPA is the use of play techniques to obtain pure tone thresholds. Air conduction testing is performed using insert earphones unless contraindicated, followed by bone conduction testing as needed. Sound field testing may be useful for some children when initially conditioning them to the task, as well as to allow parents or caregivers to observe. Thresholds are obtained between 250 Hz and 8 kHz in both ears if clinically feasible. The expected child response is motor response in response to hearing a sound, example, the listen and drop task by using the stacking rings. Moving on to the next slide, It is conventional audiometry. Conventional audiometric techniques, example, pushing a button or raising a hand in response to a sound, can typically be used once the child has reached the developmental age of 4 to 5 years. Air conduction and bone conduction testing is completed bilaterally using masking as necessary to prevent crossover. Insert earphones are typically used unless contraindicated for air conduction testing and for delivery of masking during bone conduction testing. Pulsed pure tone stimuli are typically used, and thresholds are obtained between 250 Hz and 8 kHz for air conduction testing and between 500 Hz and 4 kHz for bone conduction testing. Extended high frequency testing may be completed if there are specific concerns about noise or ototoxic exposure. Moving on to the speech audiometry. Speech audiometry measures are used to cross-check pure tone thresholds, aid in determining the site of lesion, plan treatment, and monitor a child's ability to understand speech. They are used to determine thresholds for speech stimuli as well as the ability to understand speech presented at suprathreshold levels. In infancy, speech stimuli can be used to elicit behavioral or startle responses. When a child can sit supported and turn their head towards sound, or be conditioned to place a block in a bucket, or perform another play task, VRA or CPA techniques can be utilized to measure thresholds to speech stimuli. Eventually, threshold and suprathreshold testing can be performed using age-appropriate and linguistically appropriate speech perception test, closed set or open set. Open set speech perception test requires a spoken or signed response, whereas closed set speech perception test allow for a pointing or other gesture response. A child's developmental age or ability and their vocabulary level are important considerations in test selection. Speech stimuli can be delivered to the child using monitored live voice or recorded speech materials. Results obtained using recorded speech materials are more reliable and accurate to allow the standardization across test sessions. Speech awareness threshold or speech detection threshold, which means SAT and SDT. And SAT and SDT is a measure of the level at which a child can detect a sound 50% of the time. This threshold does not assess a child's ability to recognize or identify what they are hearing. SAT or SDT testing utilizing monitored live voice may facilitate engagement and provide greater flexibility in this population. Insert earphones are utilized if possible to obtain ear-specific data. However, measures in the sound field can be utilized to familiarize the child with the sounds and the audiologist with the child's response patterns. Speech recognition threshold SRT. An SRT is the lowest level in decibels at which a child can correctly identify a word 50% of the time. If possible, SRT are obtained in both ears utilizing insert earphones and familiar and age-appropriate spotty words. Word recognition testing. It is completed at suprathreshold levels to assess a child's discrimination ability using age-appropriate list of phonetically balanced monosyllabic words. The presentation level is often 40 dB to 50 dB above the child SRT or at their most comfortable listening level. Word recognition testing is intended to provide an assessment of a child's maximum discrimination ability. Therefore, various presentation levels may be used. Results are recorded as percent correct. Previously, we discussed about the assessment protocols such as taking case history, otoscopy, tympanometry, autoacoustic emissions, ABR, auditory brainstem response test, ASSR, BOA, CPA, which means behavior observation audiometry, condition play audiometry, visual reinforcement audiometry. These all are the assessment that we already discussed. Next, moving on to the next slide, it is treatment planning. Child and family centered treatment planning for children who are deaf and hard of hearing with hearing loss of any type should include participation and input from the child and family as possible. This includes child and family education and counseling. Priorities and goals for intervention are jointly agreed with the recognition of the family's preferences, values, beliefs, culture, and linguistic background. Recommendations for amplification, hearing assistive technology system, educational service implementation, direct intervention, or referrals to other professionals occur as indicated. Oral rehabilitation part. Oral rehabilitation can be defined as an ecological interactive process that facilitates one's ability to minimize or prevent the limitations and restrictions that auditory dysfunctions can impose on well-being and communication, including interpersonal, psychosocial, educational, and vocational functioning. Habilitative services refer to those services focused on attaining listening, language, communication skills that have yet to be acquired. Example, in case of a child who is identified with hearing loss prelingually. Rehabilitative services refer to those services focused on maintaining, re-establishing, improving current listening, language and communication skills. The oral rehabilitative process is designed to be interactive, individualized, and child and family centered. The role of audiologist and SLP, which means a speech language pathologist, in the profession or rehabilitation services for children who are deaf and hard of hearing may be complementary, interrelated, and at times overlapping. Amplification is a comprehensive plan of care for a child who is deaf and hard of hearing may include the selection and fitting of a sensory device, for example, hearing aids or cochlear implant. This process will include instruction and education on the effective use and appropriate care of the device, as well as counseling on the adjustment to the device and realistic expectations for benefit and improvement. Hearing aids for children. Hearing aids are the devices which amplify the surrounding sounds. Hearing sounds and words can help children to learn to talk and understand. Children with hearing loss may have trouble in developing speech, language, and social skills. They may have trouble in learning in school and may have difficulty in communicating with friends. It is important to have your child hearing tested by an audiologist and get them help early. If needed, an audiologist can help to find the best hearing aids for your child. Child may need a hearing aid in one or both ears according to the child's degree of hearing loss, and it also depends upon the type of hearing loss. Getting hearing aids early can help the child develop communication and social skills. Even babies and very young children can wear hearing aids. Hearing aid evaluation and selection, which includes hearing aids, must be selected carefully for each child, as I already told, according to the degree and type of hearing loss. When choosing what hearing aids are needed for a child, the audiologist will consider some important information such as the degree and type of the child's hearing loss, the durability of the hearing aid, the service from the manufacturer, the hearing aid ability to connect to other devices. There are different types of hearing aids. The behind the ear or BT hearing aid is the most common for young children because it can attach to different ear mold types. The ear mold is easy to replace as your child grows. The ear mold is easy to handle and clean. It works with many types of hearing loss, and the ear molds are soft and safe for small ears. Other styles are more common for adults and older children. Getting your child used to hearing aids, it takes time to get used to wearing hearing aids. Your child may need help putting and keeping the hearing aids on and adjusting them. You can start by putting the hearing aids on your child while you are doing something fun. Gradually increase how long they wear them until they can wear them for the whole day. Hearing aids are easy to lose. Therefore, there are headbands and special tape that can help to keep the hearing aids in place. Your child's audiologist may show you how to use the hearing aid clips and how to pin the hearing aid to a piece of clothing. Taking care of your child's hearing aid, you should check your child's hearing aids regularly to make sure they are working correctly. To keep your child's hearing aid working properly, it is important to check the batteries often and keep spare or rechargeable batteries on hand and in a safe place. Clean your child's hearing aids according to your audiologist's instruction. Keep your child's hearing aids dry. Talk to your child audiologist about how to do listening checks on your child's hearing aids. Bone conduction hearing aids. Bone conduction hearing aids, also known as auditory osseointegrated device (AOD). It is designed to transfer sounds through bone conduction to the inner ear. The system consists of a sound processor and a coupling mechanism. The bone conduction device picks up sounds using microphones. The device then changes the sounds to vibration and sends it to the child's skull through an abutment. A magnet located just under the skin or through a soft band. The sound travels to the inner ear through bone conduction and bypass any problems in the outer or middle ear. Children who are considered candidates for a bone conduction system are not able to use or benefit from traditional hearing loss. It includes children that have a conductive hearing loss, which means the hearing loss involving the outer and middle ear, or a mixed hearing loss, which means hearing loss that affect the outer, middle ear and as well as the inner ear. Children and adults with single-sided deafness, which means a profound hearing loss only in one ear and normal or near normal hearing in the opposite ear. Hearing aids may be attempted first in some cases. For some hearing aids may not be an option. Some children are born with condition that results in conductive or mixed hearing losses. Some of them more common conditions are oral atraxia, which means no ear canal or opening of the ear canal. Ear canal stenosis, which means small ear canals. Other children develop a conductive or mixed hearing loss later in life due to chronic infection or disease in the middle ear, cholesteatomas or chronic drainage that prevent the use of a hearing aid. In these cases, we can use bone-anchored hearing aids. Cochlear implant. A cochlear implant is a device implanted to the inner ear directly to stimulate the hearing wave or the auditory nerve. Cochlear implants may be needed when hearing aids no longer works for a child, mostly to the profound hearing loss. In that cases, there is no benefit with the hearing aids. In that cases, it will be more effort to use cochlear implant. Placing a cochlear implant requires an outpatient surgery and your child will need to learn how to use the device. This typically involves training with several professionals including a team of audiologists and SLP to make sure the implant is being utilized in the best way possible. Selection criteria of children to use cochlear implant include child about 12 months below 7 years in prelingually deaf children. At birth, the cochlea is fully formed but the auditory pathway is not. Auditory pathway is dependent on stimulation for its maturization and this stimulation is vital to acquisition of speech and language skills as well as amount of cognitive development. Postlingual deaf, no age limit. Degree of deafness, as we already mentioned, profound, which means above 90 dB. SNHL with poor discrimination in both ears with cochlear nerve. Respond to hearing aid to those who do not benefit from a hearing aid at least 3 to 6 months of use. Absence of contradictions. Cochlear aplasia or absent cochlear nerves are absolute contradiction to cochlear implantation. Factors that affect pediatric cochlear implant performance includes age of implantation, hearing aid experience, training with amplification in case of some residual hearing, presence of other disabilities, parent and family support, etc. Auditory Verbal Therapy (AVT). The goal of AVT is to enable children with hearing loss to grow up in regular learning and living performance or environments so that they can become independent, participating and contributing citizens in mainstream society. Auditory training is a set of procedures aimed at helping the orally handicapped become more proficient in attending to the sounds of speech, discriminating one from another and affecting on increase in retention of sounds according to Kelly at 1953. The candidacy includes post-cochlear implantation to accelerate the learning process that often occurs during the first months following implantation. Post-inquiring hearing loss following trauma or the injection of ototoxic drugs to adjust to their radically altered listening state. Hearing aid used for the first time or change in hearing aid model as hearing status may differ. Almost all children with meaningful hearing loss can benefit from auditory training. Next, moving on to the speech reading. Speech reading, the integration of visual information with auditory information for enhanced understanding of speech. Speech reading does include lip reading, but also capitalizes on gestures and body language, facial expression, situational clues, linguistic factors, and any other auditory input that is available to the individual. Lip reading is the visual differentiation and comprehension of the sounds in words and sentences. Gestures or body language include any body movement accompanying the spoken utterance that add meaning. For example, go with a finger point. Facial expressions are similar to body language and add information for the listener, such as the emotional tone of the comment and whether it is a statement or a question. Situational clues that assess the deaf or hard of hearing listener are contextual cues such as a child's mother with her hands full standing in front of a door saying, "Open the door, please." Linguistic factors that rely on the redundancy, that is a natural part of language, assist children who are becoming more familiar with spoken English. The prerequisites of auditory training includes early amplification, choice of aids, monitoring hearing aids, frequency response, constant hearing, auditory processing, critical period or maturization, loudness level, etc. Stages of auditory training include awareness or detection of sound, discrimination, identification, and comprehension. Hearing assistive technology systems means frequency modulator systems or FM systems are the hearing assistive technology system most often used with children. These systems are easy to move around and not easy to break. They are useful on noisy places like the child's classroom. It is good to start using hearing assistive technology system when your child gets her hearing aid or cochlear implant. There are 5 general types of assistive listening devices such as audio induction loop, frequency modulated system, infrared system, personal amplified system, and Bluetooth system. In this webinar, I have discussed about the assessment and treatment planning of hearing loss in children. Hope all you got understood, and the references I got it from the books of or articles of oral rehabilitation and pediatric audiology. Thank you.